Good morning, everyone. Thanks so much for joining us. I'm Debbie Hart, the President and CEO of BioNJ, the Life Sciences Trade Association for New Jersey. So welcome to what I guess is actually our first official program of 2022. Ironically, if it weren't for COVID, we would have been at our annual meeting last evening. As you probably know, we had to delay that until June 9th, but that's okay. We'll have even more fun on June 9th. So I hope you, your colleagues, your families are staying safe and well in what continues to be a difficult time, although perhaps we may hear today maybe a little less difficult, but we'll wait for the experts to tell us all about it. So thanks for joining us for this morning's important and timely conversation. As you know, our mission at BioNJ is to ensure a robust life sciences ecosystem where innovation is unencumbered and patients can then access that innovation. And today's event is, I think, a prime example of the programs and resources we offer at BioNJ, bringing our members our work to help support your work in the future, developing the future of medical innovation. So before we kick off the program, a special shout out to today's sponsors. Once again, Faegre Drinker and PTC Therapeutics, amazing partners, both of them. We'll hear from Lynn Anderson today and Martin Rexroad and Lynn partner as our HR committee chairs, and we thank both of them. And this morning's webinar happens to be brought to you by BioNJ's HR committee, and we'd like to thank that group, a hardworking group, for their continued work in bringing educational programs to our community. So we are excited to have two of our most popular speakers back with us again today. So we're going to get started. We encourage and invite you to submit questions via the Q&A box if you have them along the way. And it's my honor to introduce our first speaker. As the foremost expert on the pandemic in New Jersey, I really can't think of a more knowledgeable leader to give us an update on the vaccine, the virus, and the variants than our speaker today. In addition to being an epidemiologist and internal medicine physician, he's the chancellor of Rutgers Biomedical and Health Sciences, as well as the executive vice president for health affairs at Rutgers, the State University of New Jersey, in addition to being a proud grandfather and just a pretty awesome all-around guy. So I'd like to welcome Dr. Brian Strom, and Dr. Strom, the floor is yours.
Thank you, Debbie. Can I have my first slide? Great. So what is SARS-CoV-2 and COVID-19? SARS-CoV-2 is severe acute respiratory syndrome related coronavirus, a particular type of virus. We've had coronaviruses around for at least decades, probably more than that, that has multiple genetic variants. SARS-CoV-2 specifically was named in February 2020. WHO named the disease COVID-19. So the virus is SARS-CoV-2. SARS-CoV-1 is SARS as the disease. COVID-19 is the disease that it causes. It's identified in late 2019. It was epidemic by February 2020 and declared pandemic by WHO on March 11th, 2020. All ages are susceptible to infection, mostly via aerosolized particles. The median age of infection is about 50, though with Omicron, there are a lot more kids being infected than was the case before as well. Vaccination has proven to be the most effective strategy for prevention and control outside of public health interventions, as we'll talk more about. Next slide, please. The Delta variant was the predominant variant of COVID-19, of SARS-CoV-2, across the US in late 2021. It was up to 99% of variants sequenced in New Jersey. Much more infectious, transmissible, and virulent, meaning making people sick, than earlier variants. And children were at higher risk of infections and hospitalization compared to earlier variants. Vaccines still provided by far the best protection from serious illness and death, minimizing severity of disease and limiting spread. The Delta was sufficiently contagious that it was roughly as contagious as chickenpox, which is among the most contagious diseases, viruses that we've known. Again, vaccines still provided by far the best protection from serious illness and death, minimizing severity and limiting spread. Surges occurred in those communities that had the lowest vaccination rates. Fully vaccinated people still got infections, breakthrough infections, but less often than unvaccinated people. and fully vaccinated people with Delta can spread the virus to others, but for a shorter time period than unvaccinated people. Next slide, please. Omicron, on December 26th, the WHO identified Omicron as a new variant of concern. Symptoms include cough, fatigue, congestion, but not the loss of taste or smell that is, seemed to be characteristic of prior variants. Omicron is much more transmissible than Delta, probably 3 to 5 times more transmissible than Delta, dramatically more contagious. Similar to measles, which requires 95% of the population to be vaccinated in order to achieve herd immunity. But it was less virulent, it is less virulent than Delta, probably because it has a stronger attachment than Delta to the upper airway, but less lung penetration as part of that. Although the illness is milder, Omicron is generating record hospital admissions across the US, and that's because it is so contagious, it's generating a large number of cases, much larger number of cases. So of those cases, a smaller proportion get hospitalized, but the total number of cases is dramatically higher because this is a phenomenally more contagious variant. With that, it has basically taken over. The illness, the incubation period appears to be shorter than earlier variants. Those who've received vaccinations and boosters tend to have milder infections. The unvaccinated, again, are at the greatest risk by far. Much lower efficacy of vaccine, though, without boosters. Requires boosters in order to be more effective against Omicron. So defenses remain the same: vaccinations, booster shots, masking, social distancing, avoiding crowds, and hand washing. Next slide. As of December, the proportion of variants sequenced in New Jersey in December 21, you can see about 85% Delta and 13% Omicron. Of course, the entire month of December. Next slide, please. By January 1st, 89% were Omicron, and essentially now 99% or more are no Omicron. It is completely taken over. And that's because it is so much more contagious than the other variants. Next slide, please. Treatment prevention to prevent or treat COVID-19, there are currently 853 unique active compounds in development, one approved, multiple others under EUA. So we now have a wave of different treatments emerging that are different and are new. Monoclonal antibodies, by the way, 2 of the 3 products on the market that had been effective for Delta are no longer effective for Omicron, and the FDA has moved to remove them for that reason. Next slide. Looking across the world, you see that much of the world is now red. This is a variant which is spreading incredibly rapidly all over the world. Next slide, please. If you look across the US, most of the country is dark red. The exception, fortunately for us, is the Mid-Atlantic. In part, that's because we started earlier. The surge began here earlier and then is now ending earlier, and in part because we have a higher rate of vaccination in the Mid-Atlantic. Look at the next slide. And these data, by the way, can you just go back one? If you look at these were data as of yesterday or the day before. If you look at today's data, you're seeing declines across the country as well. Still high. These risk levels are based on case rates, still high, but declining now across the country. But declining more in the Mid-Atlantic than in the rest of the country. Next slide. If you look at the average positive test rate across the US, that is of all tests that are done, what proportion are positive? You can see we peaked about approaching 30%. We're now across the country between 20 and 25%. As perspective, WHO likes to see that below 5%. So what this means when you have 20, 25% positive tests, it means there's a whole lot of disease out there that is not being detected. So the number of cases is much larger than the number of cases that we're being told about. Next slide, please. If you look at the case fatality rate, interestingly, starting in late December, it started dropping. Case fatality rate is of everybody who got sick, what proportion dies. This was approaching 2%, and that's what made the COVID so much worse than flu. People died of the flu too, but the case fatality rate for COVID was 20 times higher than the case fatality rate for flu if you're not vaccinated. What vaccination did is it brought that case fatality rate down markedly, and we'll come back to that. Next slide. If you look at the percentage of the US population vaccinated, you see the results here. Single vaccination dose is beginning to approach 70%. Fully vaccinated is a little bit above 60%. Next slide. If you look at the data in New Jersey, we're doing much better. 87.5% of the population have received at least one dose of vaccine. 73% are fully vaccinated, defined as 2 doses. 31% essentially have received a booster dose on top of that. So we in New Jersey are doing much better than the rest of the country. Next slide. But if you look at the risk levels in terms of number of cases, these were the data in February 21. Next slide. These were the data in May 21. We were doing much better. Next slide. These were the data in November 21. Next slide. And these are the data in February 22. So number of cases have dramatically shot up, and this is due to Omicron. But number of cases is misleading, number of cases by itself, because we have a lot more testing than we used to have years ago. And so a lot more cases are being detected. More meaningful is number of hospitalizations, and there's a 2-week lag, and the number of deaths, there's a 2-week lag after that. However, next slide, please. Even looking at number of cases now in New Jersey, you see a dramatic drop off in number of new cases. Next slide. And if you look at number of hospitalizations, you also see this dramatic drop off in number of hospitalizations. We hit close to the peak in the prior surges. And as healthcare providers, we again had to start postponing elective procedures because of that, but it's dramatically dropped off. The other thing that's not obvious in these data is the data are misleading because on the order of half of these cases were incidentally found. That is, they were people hospitalized for other reasons, who while they're in the hospital, they were found to have COVID. So the cases, though the number of hospitalizations with COVID were peaked close to where we were in the past, the number of hospitalizations for COVID were probably about half. And then when people were hospitalized, they were in the hospital for a shorter time period. They were less sick. Fewer of them were on ICUs or on ventilators. This has been a milder disease, at least part because it's a milder disease in general, at least part because of people being vaccinated. If you look at the people who are hospitalized now with Omicron, they're almost all people who had not been vaccinated. So once we went past Gamma to Delta, vaccines no longer completely prevent infection. They reduce the risk of infection. They don't prevent infection. There are breakthrough cases. Certainly with Omicron, there's more breakthrough cases, but those cases are milder disease. And so way fewer of them are hospitalized. If you look at hospitalized cases, they're almost all people who did not get vaccinated and certainly didn't get boosted. If you, next slide, please. You look across the state, look across the country and the state, very recent numbers. Worldwide, there are over 380 million confirmed cases. These are confirmed cases, undoubtedly. Total number of cases is many times that. If you look at confirmed cases in the US, they exceed 75 million. Again, the real number of cases is undoubtedly much higher than that. You look at the number of deaths in the US, it is now approaching 900,000 deaths. 900,000 people who died in the last 2 years, who most of whom would not have died were it not for this disease. And this doesn't count the people who died from heart attacks and strokes and other things because they didn't come to medical attention or couldn't get medical attention because of all the COVID cases. Confirmed cases in New Jersey approaching 2 million. Again, these are confirmed cases. Total cases undoubtedly much higher. Confirmed deaths in New Jersey approaching 29,000. Current hospitalizations in New Jersey are now down to 2,000. Currently on ventilators, only 187. Currently in the ICU, 462. Current positivity rate for the state of New Jersey is 11.5%, much better than the rest of the country. but still higher than the 5% threshold that the WHO uses as a rule of thumb. Rate of transmission is 0.55. This is striking. To remind people, rate of transmission is of every case, how many cases does it cause? In New Jersey, we had been at a rate of transmission close to 2. So every case generated 2 additional cases. When the rate of transmission is less than 1, that means every case is generating less than 1 case, where the pandemic is shrinking. This rate of transmission of 0.55, which is what it's been for the last 4 days, is the lowest I remember in the pandemic, and it really means the pandemic is melting away. The number of new cases is dramatically dropping. Next slide. You look at our data at Rutgers, and I won't go through this in detail. It tracks each peak that we had when the athletes returned, when the students returned, Thanksgiving, people partying, et cetera, each time beat back by our very aggressive contact tracing. You can see for us as well, it went up and then has gone way down since then. Even over the Christmas holiday, we had more cases per day over Christmas when the university was closed than we have now in a week. Massive surge. That said, we had hundreds of cases of Omicron. Not one was hospitalized. Not one was hospitalized. And that's because we have a fully vaccinated population, students and staff and faculty. Next slide, please. If you look at our testing update at Rutgers, you can see the last date we have data for by week is the week ending January 29th. We had only 27 cases in the course of that week and a proportion positivity of 2.78% that compares to the statewide data of 11.5%. So again, we remain an island of health in the sea of disease, but the sea of disease is also doing much better than the rest of the country is doing. As this pandemic just melts away as fast as the surge happened, it is disappearing. That was the experience in South Africa. We weren't sure whether it was going to happen here because in South Africa it was summer and here it's winter. But it's certainly happening here too. New Jersey and the Mid-Atlantic first, we're beginning to see these declines now in the rest of the country as well, although there are certainly plenty of places in the rest of the country where hospitals are still at breaking point, given the number of hospitalized cases. Next slide. So the goal of a lot of these measures is really to flatten the curve. And you've heard about that for the entire pandemic. And the idea is that there's health system capacity can only handle a certain amount. That absent intervention, we would exceed that certain amount and people would die simply because they couldn't get enough care. That happened in Italy. New York probably had happened too with the first surge. We came awfully close to that in New Jersey in the first surge. And the goal again is if there's going to be cases, at least prolong them, delay them so that the healthcare system can handle it. And we don't end up unnecessary deaths from COVID and other things because of that. We have succeeded again in New Jersey in handling that. The number of hospitalizations has markedly dropped. We are not at peak. We are doing elective procedures again, restarting elective procedures again as we pass this peak. Next slide. Will Omicron create herd immunity? As a reminder, herd immunity, on the left-hand side, without herd immunity, each case might lead to 5 additional cases, or 6 in this example, and the untreated and unintervened are 0 for SARS-CoV-2 is between 5 and 6. That's what would happen without intervention, no public health interventions, no vaccination, whatever. The goal of herd immunity is if each case gets surrounded by immune people, you have a lot less active disease that emerges. We'll never get to complete herd immunity because of people who aren't going to get vaccinated. But we have achieved probably a steady state now where Omicron is hitting a wall of immunity, as one of my colleagues refers to it. So it's everybody in the mid-Atlantic and New Jersey certainly has either been vaccinated or gotten sick. And we will probably see that worldwide. Omicron is so contagious that essentially it becomes a disease of the non-immune, of the non-vaccinated. And it's so contagious that most of those non-vaccinated will get sick. Unfortunately, too many of them will be very sick. Those who are vaccinated, you certainly see breakthrough cases. They just won't, they don't get as sick. Next slide. A little bit of epidemiology 101, epidemic cases. Epidemics are where you have widespread occurrence of disease in a particular place and time. Examples are SARS. And again, SARS is a related coronavirus. Fortunately, it wasn't as contagious. It was more fatal, more virulent, but not as contagious as COVID. MERS, another related virus, typhus, cholera, epidemic diseases. Pandemic is when the epidemic disease becomes prevalent across a wide region, continent, or worldwide. An example is the bubonic plague. Another example is 1918 flu. Another example was COVID-19, Gamma and Delta. Pandemics tend to burn themselves out as most people get immune to the disease. And then you move on to being endemic, when a disease is regularly found in a population and just recurs, never disappears, recurs, you learn to live with it. Malaria, influenza, HIV, AIDS are an example. And I would posit that COVID-19 Omicron is now becoming endemic. Will we have another surge? We will have small surges, no question. We can't predict what's going to happen with future variants. There will be future variants. Viruses mutate, that is the nature of what they do. But Omicron is so contagious that in the same way as Omicron pushed out Delta, any new variants are going to have a hard time taking over because they would need to be more contagious than Omicron. Next slide, please. A reminder, get your flu shot, avoid the twindemic. It's more important than ever now to get your annual flu vaccine. It is not too late. Preventing a twindemic surge of both COVID-19 and flu. Flu vaccines will not prevent COVID-19, but they will avoid confusion between the two diseases with similar symptoms, reduce flu illness and hospitalization, and conserve resources, protecting hospital beds. Here you see me and my colleague, who is my Senior Vice Chancellor for Clinical Affairs, getting our flu shots last November, if I remember right. Right. Next slide, please. COVID Connect, for those who are experiencing undue stress due to the spread of this disease. This has been enormously stressful to the population at large. The UBHC, our University of Behavioral Healthcare, and the New Jersey Department of Human Services have launched a COVID Connect hotline available to all New Jersey residents. This is the phone number. It's 9 a.m. to 5 p.m. One of our specialists will conduct a brief triage and assessment of your immediate symptoms related to the spread of the COVID-19 virus. You'll be offered telephonic support and referred to a provider. All referrals are to licensed treatment providers, and our staff will follow up with you to ensure a successful connection. This has been a disease which has dramatically impacted everybody, not only medically, but also due to the mental health impact. And we as a society need to be prepared to be able to help our colleagues. Next slide. In addition, I want to highlight this sign from the New Jersey Turnpike as we thank our healthcare workers from the bottom of our hearts. We have 1,000 healthcare providers at Rutgers, partnered with the RWJ Barnabas Health people and partnered with the rest of the healthcare community, of course, the state. They have put their own lives and the lives of their family at risk to take care of the rest of us. Many of them, literally during Omicron in January, 30% got sick, despite all being vaccinated, and needed to be pulled out. And those that were remaining had to work that much harder because of it. And we just are extraordinarily grateful. Next slide. We are back at Rutgers. We are back in full speed, in-person education. Now, well over a year after New Jersey's first case, we continue to find the best in ourselves and in Rutgers. We are extraordinarily proud of what we have been able to accomplish pulling through this as a university, making enormous contributions to the state, to the country, to the world from a scientific point of view, and through provision of care accordingly. Next slide. Recommended reading, a recent poignant and powerful opinion piece in the British Medical Journal. Working in healthcare right now means being asked to do the impossible, then being abandoned to our inevitable failure. A piece by Dr. Esther Chu, an emergency physician at Ohio State University. For healthcare workers, the single worst stressor is the feeling of being lost in the increasingly vast gap between the care that they want to deliver to their patients and what they can actually provide. This has been an incredibly stressful time for healthcare workers, both the stress that they've been going through, the risks they've been taking, the risks they're taking for the patients. And the sad part is we moved in this past surge from a time where healthcare workers are seen as heroes to a time that we need police to defend them against their patients, because so many of the patients are anti-vaxxers and the population is so polarized. Next slide. Reminder, Rutgers podcast on the pandemic, a series of podcasts we've had. The next one is from Mary O'Dowd, the former New Jersey Commissioner of Health, who is now our Executive Director of Population Health. Season 2, episode 6 on kids and COVID. What do we know? Because starting with Delta and now with Omicron, children are being more infected than they were before. And certainly there are other diseases, MIS and otherwise, that they've gotten. Guest will be Dr. Larry Kleinman in pediatrics. This is a Rutgers Cast series where university experts and leaders in health examine the critical challenges we face in our recovery from the COVID-19 pandemic. It's available at https://anchor.fm Rutgers Cast. And again, this will drop on February 22nd. Last slide. Little cartoon, if you can't read the text on the right-hand slide, it's reproduced in bigger writing on the left-hand side. How will we know if our pandemic guidelines work? Asked Piglet. The answer is the world will think we overreacted. So even when we're right, everyone thinks we're wrong. And the answer is welcome to public health. So with that, thank you, and open to questions.
What an interesting end to your story. And actually, maybe we'll start there, Dr. Strom. Thank you so much. So is this the end of the story? I mean, are we declaring victory, or what say you?
It's definitely not the end. And certainly is not victory with close to 900,000 people died, most of whom unnecessarily. If we had done it right, most of those deaths would have been prevented. And it's appalling the way our country handled it. Is it over? No, but it's entering a new stage. Now it becomes endemic. Now it will come back every year. We will continue to have, it'll be continuous. It'll then come back. We've had coronaviruses for years. We still have the 1918 flu around. It just doesn't kill people the way it used to kill people. Will we continue to need boosters? We don't know yet. But it's not disappearing, but we will learn to coexist with it now as an endemic disease. Some people will continue to walk around with masks as they always did. Probably we'll start seeing, like in Europe, mask mandates start to be dropped. What it really required was the population to be vaccinated. And unfortunately, not a large enough part of the population got vaccinated. Instead, people got infected. We had an opportunity for this to be over. When we were looking at the Gamma variant, vaccination prevented breakthrough. And therefore, if everybody is vaccinated, it would have ended the disease. That's not the case now. But Omicron is so infectious that essentially everybody who's not vaccinated will get it around the world. And so there will be future variants. There will be fewer of them. And what we can't predict is there anything that's going to be worse than Omicron going forward. But to be worse, it can certainly be more virulent, but to take over, it also needs to be more contagious. And that's much less likely.
Okay, so how do we know how to act? I mean, will you be wearing a mask? You know, what's happening at the Strom household in the future for holidays and that sort of thing? You know, what do we make of all this?
So great question. Do I wear a mask going out? Yes, I do. I am having one-on-one meetings with people who are vaccinated who are not. In group settings, I'm still wearing a mask. Will that end? Yes. I mean, I think we will continue to see over the next few weeks it dramatically drop, continue to dramatically drop, and mask wearing will become more optional, and then it'll come back again as we have mini surges. People will go back to masks and come back again, and we'll go back and forth accordingly. What's happened in the Strum household? We went on our first flight and vacation in 2 years, and in early January, to protect that, we basically hibernated for all of Christmas. My granddaughter, 2.5 years old, as you mentioned, who brought along her parents with her, went to their in-laws for Albuquerque over Christmas break. And my son became patient 0. 11 of the 15 got sick. Who knows, the other 4 probably got infected, but weren't symptomatic. 11 of the 15, including 1 who was immunosuppressed, and my 2.5-year-old granddaughter who wasn't vaccinated. Fortunately, none of them were serious. And they recovered quickly enough that they were still able to join us on vacation. But that's sort of a classic story of what Omicron is about. And if you expose yourself, you're going to get sick. Fortunately, if you're vaccinated, the sickness isn't going to be serious. And that's what we're going to learn to live with. It's saying, you know what, it's a cold. It's like the flu. We tolerate the flu. The flu always killed 20 to 50,000 people a year in the US. And we tolerated that as acceptable. We weren't going to shut down our economy for that reason. 500,000 to 1 million people we shut down our economy for in order to prevent it. It would have been worse. Case fatality rate in the flu is 1/20th that of COVID-19. With vaccination, it should be comparable to the flu. And so this will become something we live with like we live with the flu. Will it come back every year? It'll be continuous. There will be many surges. Will we continue to need vaccinations, boosters like we do with the flu? The flu mutates even faster than Omicron does, even faster than COVID did. So, will we continue to need boosters? We just don't know yet.
Okay, so we're going to be watching you. I was thinking maybe we need an app, a BioNJ app that's, whether Dr. Strom is wearing a mask today or not. Goodness. Meanwhile, we have some more time here. If you have some more time, because we have a lot of questions coming in.
Sure.
Okay, terrific. Great. Well, thank you. So let's see. So for someone who was vaccinated or who was, triple vaxxed and received, let's say, their third vaccination in September, what do you advise? Just hang tough and hang tight and wait for more info, or, do they need anything else?
Yeah, exactly. At this point, just hang tight. So I got my booster in August. So I'm sort of one month even older than that. Should we have another booster now? It's too early to know. What's clear is antibody levels wane. They drop. But yet we're not seeing the clinical risk go up with that in terms of serious disease. Keep in mind that we measure antibodies, but we have a second, because they're easy to measure, we have a second immune system, so-called cellular immunity, T-cell immunity. And some immunologists think that's even more important than the antibodies. The antibodies will decrease your risk of getting infection. You've got antibodies, the antibodies combined with the virus, fight the virus, and don't allow it into your body. But once it's in your body, your T-cell immunity, your cellular immunity gets mobilized. And it is theoretically possible that these 3 vaccines will be enough even for lifetime protection against serious disease. We just don't know yet. It hasn't happened yet. So far, the experience has been that virtually everybody who's gotten seriously ill is either immunosuppressed or not vaccinated. So if you're fully up to date on your vaccine, that is, you have 3 vaccinations, the answer is to hang tight. And we just don't know yet. I mean, Israel has moved to a 4th dose that the rest of the world has not, and that the data aren't there yet to justify that.
Okay, so it's not that the data aren't there. I'm sorry, it's that the data aren't there. It's not that because everyone hasn't gotten their 2nd or 3rd yet that they're not pushing the 4th. It's correct. The data. Okay, all right. Well, that's good to know.
Plenty of vaccine out there. We certainly give it at our 3 sites at Rutgers. You don't have to be at Rutgers to come to our site. If you're not fully vaccinated and up to date, feel free to go to a Rutgers site to get it. Lots of vaccine available. There's no shortage. The reason we haven't recommended a 4th dose yet is the data just aren't there to support that. But that might happen. It wouldn't be a terrible surprise if that happened.
Okay, all right. We're going to change course just a little bit. We're getting questions. How reliable are the home tests? And the whole question of testing.
Testing is complicated. So the best tests are the so-called PCR tests, polymerase chain reaction tests. But most of them, not all, but most of them require being sent off to a lab and come back, and it's 2 or 3 days before you get an answer. And when the testing gets overwhelmed, it's even worse than that. Anyone who wants can get tested for free in the state of New Jersey. Anyone who lives in New Jersey, it's done for free. There's a website, you register, they will watch you, they'll provide you the specimen. They're using the Rutgers saliva test, to be clear, in the Rutgers lab that we sold accordingly. That's what that testing is. But it takes 2 or 3 days. And the problem with, and that not because it's a saliva test, but just the PCR testing in general. The trouble with that with Omicron is it operates so fast. In the meantime, if you have the disease, you're spreading it to other people. So what we are more dependent on, therefore, is antigen testing, including home tests. And the home tests now have gotten pretty good. If you do it correctly and you do it right, it requires a higher level of the virus to be positive compared to a PCR. So PCR tests are more sensitive. You certainly have some people who are PCR positive who are antigen negative because the viral level is low. But that viral level being low, they're probably not contagious, or at least we hope that they're not contagious. So if you're positive on a home test, you're positive. That's reliable. If you're negative on a home test, it doesn't prove you don't have it, and you may want to test a day or two later. Treat yourself as if it's positive if you're symptomatic, even though it was negative, and test again a day or two later in order to make sure. In the meantime, the viral levels will have gone up. If you test a second time or a day or two later and you're still negative, then whatever you have causing your symptoms is not COVID. It's flu or some other cold or even some other coronavirus. Testing used, that's clinical testing used if you're symptomatic. Surveillance testing, that is testing asymptomatic people, really just isn't a way to control this virus unless you're going to test essentially every day, because the virus is just so contagious and the incubation period is so short. So, for example, during the peak of the surge, we had people interviewing for our medical school dean position. But we did it testing them every day, and everyone they came in contact with, we tested every day with rapid tests, with antigen tests as part of that to protect them accordingly. And they were, of course, fully vaccinated and up to date, and so was everybody else that they interacted with. So testing could be used that way, but there aren't that many tests around to be able to test the whole population in the US every day. I mean, it's just not practical. So the answer, testing has appropriate uses, certainly if you're symptomatic, certainly, for example, if you're going to get together with somebody who's high risk because they're older or they're immunocompromised, it makes sense to test before you get together with them in order to find out. And again, that should be a rapid test so that you know the results right away. Because if you wait 3 days, by then you may be infected, even if you weren't infected 3 days before.
Okay. So what's being done to monitor the appearance of new variants? How much sequencing is being done?
Not enough in the US is the simple answer. It's being done much better in other parts of the country. It is increasing in the US though. So that we're certainly doing better than we did 2 months ago. But Omicron was discovered in South Africa. It didn't mean it wasn't in the US. It probably was. We just didn't know about it yet. So the amount, the doing sequencing requires having the specimen and doing another test in follow-up of that, which takes a few days. Our lab that developed the Rutgers saliva test also does sequencing. And so we were sending Rutgers specimens to them to be sequenced when no one else was. Now there's much more sequencing being done across New Jersey and across the country, just not as much as is being done in other countries, and not as much as I would like to see.
Is infection inevitable?
Probably. Well, I guess it's not inevitable if you're vaccinated. Let me be clear, and be vaccinated and up to date. But for those who aren't vaccinated, it's probably inevitable. Unless you sit as a hermit at home, it would be inevitable. Again, there are people who are very high risk, people, transplant patients, cancer patients, who probably still shouldn't go out because the infection is so widespread right now. Again, that will drop. It is dropping now. It will continue to rapidly drop in terms of the risk of getting infected. But as I mentioned, during the Christmas break, our family, we isolated ourselves like we had in the beginning of the surge, at the beginning of the pandemic, even though we were fully vaccinated, in order to protect ourselves from getting infected because it was so widespread. So the background rate of disease is critically important to the risk of infection. And the background rate of disease was so rapid, was so high and so rapid. It is now dropping rapidly. It's not low yet, to be clear. It is not low yet, but it is rapidly dropping and will become low over the next few weeks and months.
Few weeks. Okay. Okay. So, our annual meeting, we're planning in person on June 9th. Does that happen?
I will predict it will. I think June 9th should be fine. The other thing you see is a difference, because it's a respiratory virus, is seasonal differences. When people go indoors, you're more likely to pass the disease. And all along, we've known COVID is more likely to be passed indoors than outdoors. Now, your annual meeting is indoors, presumably. But it's still a lot less disease will be around simply because it's spring, as opposed to winter. Everybody's not indoors. In fact, June is probably a perfect time because in the summer you're indoors again with air conditioning.
Wonderful. Okay. We will be requiring vaccination, and Dr. Strom will be receiving a COVID Hero Award. So you might want to tune in or come along for that, because you won't be able to tune in if we're in person. I love this question. I'm a minor in psychology in college. So do you see a link between the pandemic and aggressive behavior? It appears that people are more on edge than ever before.
An interesting question. Yes, there is clearly more aggressiveness. There's more crime. That has all gone up. It is partly a reflection of just general stress in the community, and the amount of depression has skyrocketed in the community. Clinically apparent depression has skyrocketed. We clearly can't keep up in treating everybody. On top of that, people are isolated. When people are by themselves and isolated, and then they'll lash out in response because they can't handle it anymore. And the net result is we see an increase in crime, no question.
Wow. Okay. So we are really running out of time. We did have a question on is there research being done on the long haul effect of no smell, taste not returning? And I do know there's an institute in Philadelphia, and if you write to BioNJ at bionj.org, we'll be happy to get you the name of that institute. Dr. Strom, you may know about it, but any comment there, and then we will have to wrap up.
Yeah, Richard Doty is one of the most, in Philly, is one of the most prominent smell researchers. He's been there for decades. When I was there as well, about it. But loss of smell and taste was characteristic of all the variants before Omicron. Does not seem to be the an effect of Omicron. Even those who lost their smell and taste typically got it back. So is it possible some people will never get it back? We just don't know yet because it's only been 2 years from the earliest cases to know that. But most people, overwhelmingly, it has recovered.
Okay. All right. Well, a little good news today. Thank you so much. So maybe we won't have to, we've been doing these for now, pretty regularly for the last 2 years, thanks to you and Lynn. Will we have to do one of these again? What do you think?
It's hard to know, what's going to happen. I mean, my guess is it's going to phase out now, and then it's going to be, you may end up needing to do it when the next surge occurs, but the next surge to reassure people that this isn't going back into Omicron. And as bad as surge as Omicron was. Again, unless there's a variant that surprised us. No one foresaw Omicron being as bad as it was. That said, over time, viruses tend to mutate to be more contagious and less virulent. That is causing less disease. COVID didn't do that. It kept getting more contagious, not less virulent. Omicron did that. Omicron was a big step toward more contagious and less virulent, the way viruses tend to do over time. So we need to do it again, I guess.
Here's the most important question. If we have to do it again, will you come back, please?
My pleasure. Absolutely.
Okay. Thank you so much, Dr. Strom. It's always great to see you. So interesting to hear you. And please stay safe and well.
Take care. Everybody, stay healthy. You've not been fully vaccinated and up to date 3 doses. Get it. Take care, everybody.
There you go. Thank you, Dr. Strom. Okay. So let's see. I guess next we're going to go to our next speaker and hear the legal update on vaccines in the workplace. So again, a dear friend, a returning speaker, a highly in-demand speaker. I'd like to ask you to welcome the other half of this dynamic duo and our friend, a partner at Faegre Drinker, Lynn Anderson, who will share the latest on the legal front. And Lynn, we are looking forward to hearing what you have to say. Please take it away.
Thank you very much, Debbie, and hello, everybody. Good morning. Yes, we are back again, but that was the most promising piece we've heard from Dr. Strom. So I'm going to go with a more uplifting scientific update that we had since we've been doing this. So we're going to talk about what's been going on. We've had some decisions from the Supreme Court. We've had some other things happening with regards to the legal implications of COVID in the workplace and what it means practically. And I know it's been a bit of a wild ride, a lot of ups and downs. So we'll try to digest what's been going on and where we go from here. So next slide, please. Okay, so SCOTUS, the workplace, and the COVID vaccine. Next slide. As we all know, the ETS, the OSHA ETS was issued, formally issued on November 5th. Lawsuits were immediately filed. It was stayed on November 6th. Those lawsuits were consolidated before the Sixth Circuit. We then heard the Sixth Circuit dissolve the stay on December 17th. We all then rushed around like crazy to comply with the ETS, not sure what would happen. And then on January 13th, the Supreme Court issued their decision that put the ETS on hold. What did that decision mean? I've broken out sort of the 3 different groups of the court and what they decided. The majority decided that while OSHA has the authority to issue the emergency standard, they overstepped this time. The concurrence, the group in the middle, basically questioned whether or not Congress even gave OSHA the authority to enact an emergency standard that has such a vast impact, a political and economic impact, which, really kind of resonated in the legal community because it questions OSHA's ability to enact standards on a more general level. And then our dissenters basically said, look, the whole purpose of OSHA is to prevent workplace harm. This was intended to protect workplace harm, so it should be upheld. That's a summary in a nutshell. One thing that was very interesting, we have Justice Amy Coney Barrett, who obviously is our newest member of the court. She actually was the person who had to decide whether or not to take up the challenge to Indiana University's vaccine mandate, which required students and faculty to be vaccinated. And unlike the OSHA ETS, which really isn't a vaccine mandate, what it is you either vaccinate or you test. That came up to her, and she could either decide to not take it up before the court or to take it up, and she declined, which meant that the Indiana University mandate would stay in place. So we were all wondering whether or not that signaled that she might be more willing to enforce the OSHA ETS, but no, she was not. She was with the majority in determining that the ETS should not be enforced. Next slide. Just to get a little bit more insight, what the majority said is they basically said, look, this is not just a workplace issue. You can be exposed to COVID anywhere. So we think it goes beyond a workplace hazard. Obviously, the dissent disagreed with that, but that was a big focus of their opinion. And therefore, they also said that OSHA overstepped because what you're really regulating is a hazard of daily living. It'll be interesting to see how this plays as far as what they do next. We're going to talk a little bit about what they do next. A couple things to pick out from the opinion that may foreshadow where they go next is they did say, look, the whole purpose of a standard, especially an emergency standard, is that there's a grave danger posed to workers. And usually that's when we have an emergency standard, it's a grave danger that's caused by something new. COVID-19 is new. And secondly, that we have to have some kind of emergency regulation to address that grave danger. The court, even the majority, did acknowledge that there are situations where we see there is a danger that might need to be addressed by a standard. For example, scientists that are working in the lab with COVID-19 for purposes of finding vaccines, finding treatments, things like that. They also talked about people that are working in close, crowded or cramped work environments. You've probably heard during the argument there was things about meat packers or people that are working perhaps very closely in manufacturing facilities, maybe distribution facilities, maybe your labs, depending on how they're set up. So we will see if we come back, OSHA comes back with something more targeted that is going to be addressed to people that are in those cramped or crowded conditions, as well as lab workers that are working with COVID hazardous materials. So next slide, please. So at the same time that we got a ruling on the OSHA ETS, we also got a ruling on the CMS rule. Now, the CMS rule obviously relates to those folks that are getting reimbursement from Medicare and Medicaid, primarily hospitals and healthcare facilities, whether it was appropriate to require them to have their workers vaccinated. And this is a vaccine mandate. This is not an off-ramp for testing. Now, interestingly, the same group, for the most part, a couple of the same people that would not enforce the ETS, primarily Justice Roberts and Justice Kavanaugh, did find that it was appropriate to enforce the CMS rule. And I think that they basically said, look, whether or not you're going to get money from the CMS, CMS has the right to put conditions under when they're going to give you that money. So we have the same sort of folks that are dissenting that were in the same camp that decided that they were not going to enforce the ETS. But if we go to the next slide, it was kind of an interesting dance. While they said we're not going to necessarily recognize the health risks for the OSHA ETS, and they did talk about the fact that it was such a broad swath of workers, over 84 million workers. They did say that we do see there is a health and safety need to enforce this for people that are going to be basically frontline healthcare workers, and that we do see there is a medical risk here that needs to be addressed. So again, trying to figure out where we go from here, to the extent that there is a medical risk, a direct medical risk for healthcare workers, for people that are on the front line. That's obviously something that courts are going to be more likely to enforce if you're an employer that's deciding whether you're going to impose a mandate either for some or all of your workforce. Next slide, please. So what is OSHA doing now that the court struck down the ETS? So last week they basically called uncle and they withdrew the ETS. But they were clear they're not withdrawing it completely. They're going to focus on a permanent standard. And so whether we're going to see a permanent standard that again is focused more on these close cramped workplaces, whether we're going to see a permanent standard that requires vaccination along the lines of an endemic scenario, like a flu vaccine for healthcare workers, to be continued. But it's not going away. And I think that also OSHA still has a whole lot of regulations out there in terms of what's required for a safe workplace. So we need to keep in mind that it's not completely done in terms of the kinds of precautions that you need as far as masking when appropriate, which we'll talk about, social distancing when appropriate, hand washing, things like that. So, but as of right now, the current ETS is kind of off the table. Next slide, please. So, as I mentioned, there are still, and here are some links, but there are still COVID protocols that are out there in terms of OSHA. So it's worth keeping that in mind. The other thing is we're still seeing OSHA inspections and OSHA activity with regards to what's called the general duty clause that requires everybody provide a safe workplace. So to the extent you have committees in place to deal with containment measures, to deal with close contact tracing, all of that is still very, very important. You still have to maintain records with regards to those measures, as well as there's if you have a work-related hospitalization or COVID death. The other thing is you do have in 28 states, there are state OSHAs that have their own rules and regulations that they put forth. So that's something that we're also watching. So it's not over yet in terms of the roller coaster, to be continued. But as far as the general ETS, as I said, that has been pulled. Next slide. Okay, now the CMS rule, I just want to make sure that that's on folks' radar screen, because the CMS covers contractors. So to the extent that you have a contract with hospitals or healthcare providers that are getting CMS money and you're going on site, then you are likely going to be getting a letter from the healthcare facility saying, we need your employees to be vaccinated. And again, there's not necessarily a testing off ramp here, unless there's going to be an accommodation for medical or religious reasons. So just keep that in mind, that if that's something that does apply to you, you should have that in your sites and be collecting records and preparing to get folks vaccinated. Next slide, please. This is a chart. This is sort of the updated deadlines now that a lot of the original deadlines obviously didn't work while we were waiting for the Supreme Court to issue its decision. And what happened with the CMS, the decisions were sort of complicated. It was stayed for some states, not stayed in other states. So that's why we have a couple different set of deadlines, and then Texas was doing its own thing. But I've listed the deadlines here, including for New York, Pennsylvania, and New Jersey. So as a reference, and I think these slides are going to be available if you need to reference them later on. Next slide, please. Now, the federal contractor mandate, this obviously is if you have a contract with the federal government, you are obligated to have folks vaccinated. Again, no testing option. This was stayed and so has been put on hold, and ultimately probably what will happen is it may get to the Supreme Court. There's been some complications in two ways. One is on January 21st, the federal court in Georgia that stayed it issued opinion that said, yes, we've stayed this as far as the vaccine mandate, but as far as requirements for masking, physical distancing, having someone who's responsible to be the person to make sure that stuff is happening, that part isn't stayed. Now, the interesting thing is there's a whole lot of other decisions out there that have stayed the federal mandate. So it's unclear whether that Georgia decision applies to everybody or just applies to Georgia. I would say to the extent that you've got a federal contract, you probably are already complying with masking and physical distancing. It might not be bad to make sure that you've got verification of policies and a safety officer who's responsible for that. The other open issue is when the executive order was in place before it was stayed, a lot of folks were entering contracts where they were agreeing to comply with everything under the executive order. The question is now, are those contracts still enforceable? Do you still have to do that? This Georgia court was supposed to answer that question. They declined. But I think what the general thought is, if you voluntarily agree to enter it, if the language is more along the lines of, here's what we're asking you to do, and we agree to do it, regardless of whether or not the executive order is in place, then it's probably enforceable. And if the relationship is such that that's what's expected, if you were doing it because it was to be compliant with Executive Order 14042, then it probably isn't. But that's something that may be relevant to some of you, not all of you. But that's the latest of what's going on with Executive Order 14042. Again, that's for if you are a federal contractor or subcontractor. Next slide, please. Okay, so big picture, how do you respond? What should you be doing? We are, and you may be needing to think about what you want to do before you jump right in to adopting a policy about whether you mandate a vaccine or you mandate a vaccine or testing. And I'll talk a little bit about that in a second. But while you collect your thoughts, at the least what you want to be doing is still asking folks to provide you with both vaccine and booster status, because a lot of our clients aren't really sure who's vaccinated. And some clients make decisions about imposing a vaccine mandate and then realize they're going to face some real issues as far as staffing, because more people than they realized are not vaccinated. The other thing is, to the extent that you may have to comply with the CMS, or you may have either just contracts where your important clients, vendor relationships, to the extent your salespeople are going in to doctor's offices or other locations, people want verification of vaccination status, you need to have that anyway. You want to make sure that you're putting together policies that kind of take into account a lot of different things and be drafting those and get ready to launch. We strongly recommend you continue the education and outreach to increase the percentage of people that are not only vaccinated but boosted. And then also the containment protocols, the contact tracing, the compliance with masking, things like that. There are, as many of you probably know, the CDC has once again at the end of the year tweaked what those isolation and quarantine protocols are. So you want to make sure you've updated what you are telling people as far as when they can come back, how long they have to stay out. And that too is linked to vaccination status, which is another reason to collect people's vaccination status. And then obviously continue to monitor what's going on with the CDC, OSHA, et cetera. To the extent that we all joke on the HR committee, we're all becoming, Dr. Stroms in training, epidemiologists without a degree. But to the extent the CDC is not one of your favorite websites, I would encourage you to keep it up and monitor it regularly. Next slide, please. So you can still choose. You still have the ability to determine what you want to do, especially in New Jersey, as far as whether you want to adopt a vaccine mandate or mandatory testing, or a combination thereof. Next slide, please. With the vaccine mandate, I do want to make clear you still need to provide testing as an alternative for those people that qualify for religious or medical accommodations. So it can't be everybody has to be vaccinated, or they're fired or they're put on leave. You still, if someone raises their hand and said, I want a religious or medical accommodation, you have to go through that interactive process and work with them. And that's, we could do a whole another program on what does or does not justify as a religious exemption, but that's still something you make sure you need to include in your policies and how you're rolling out your policy. A lot of folks are considering whether or not they limit the vaccine mandate to certain portions of the population. People that are coming on site, people that need to travel to locations that are going to require mandates. Some folks still have remote workers that are going to stay remote for the foreseeable future, and whether those folks are exempted for now. So those are considerations that you can talk about when you're trying to craft your policy. Clearly, whenever you're going to be combining people, bringing people together, you're going to need to make sure that you're covering those people as requiring the vaccine, so that you don't have situations where if you excluded someone and then things evolve and they start coming back on site, you've got to make sure you're capturing them. The other thing is we highly recommend that you align with whatever you do for new hires with what you're doing with your existing workforce. So those either the total population or those groups of folks, whether they be salespeople, lab workers, office folks, are being treated in the same way. Next slide, please. So if you're going to go the route of you can either be vaccinated or agree to mandatory testing, we've heard Dr. Strom's opinion on how effective weekly testing is, which is what the OSHA mandate talked about. So you can take that into account in terms of what kind of testing you decide to request. There are a lot of different things you can decide on how you're going to roll this out. Some folks are just adopting what the OSHA ETS specified for their testing protocols. You want to consider in terms of what types of tests you want to require. OSHA did say that you could not have a self-administered and self-proctored test to limit the possibility of people, using someone else's test results to show that they're clean. The other thing is you obviously probably want to require masking for unvaccinated employees. And we've seen an update just recently that now N95s and KN95s are the masks that are preferred to be used to truly protect against spread. The other thing is make sure you've got a protocol about what to do if positive, and preferably so people are testing before they enter the workspace so that you don't have someone show up and then have to go home. But those are things logistically you really want to think through. The other thing is in New Jersey, you do have to pay for the testing, the test, and likely the time for your non-exempts. And that's something you're going to have to think about as far as how you handle that. And some folks have said, I'm going to allocate X amount of time for doing the testing, especially if I require them to go to a site. And if it takes more time, then let me know. But those are all things you need to think through. Next slide, please. Okay, now when you are talking about what you're going to roll out as far as a company-wide policy, I would make sure that you're aware that there's a lot of activity happening on the state and local level. And what we're seeing, especially now that the ETS has been withdrawn, that a lot of states had laws that said, look, if you're going to have a vaccine mandate, you have to provide exemptions. A couple states have said you can't have vaccine mandates. Some They, like New York, has said we need a vaccine mandate in New York City. So you got to make sure that you understand where your workforce is located and what's happening in those states and cities. Next slide, please. Here's an example of what we have right now. As you can see, in Tennessee and Montana, vaccine mandates are banned. So to the extent you may have salespeople or other operations in those locations. The yellow states are states where there are very broad exemptions allowed for religious or medical reasons. We've been spending a lot of time with Florida because Florida has 5 exemptions options. For religious exemption, you basically simply say, I have a religious objection and I want an accommodation, and the inquiry stops there. There's no back and forth. The same thing with the medical exemption. Or I agree to test and it stops there, not even if there's a medical or religious reason. Or I'm going to provide proof that I currently have antibodies, and so it stops there. And we talked to Dr. Strom about that in the green room this morning, and he said that just makes no scientific sense, but that's what it is. So just be aware that even if you do have a mandate, you're probably going to have to deal with testing options if you have employees in any of these states, especially Florida and Texas, which is we're spending a lot of time dealing with exemptions there. Next slide, please. New York City, I think we're all probably aware of that. There is a vaccine mandate in place. There is the option for medical or religious accommodations to the extent, and this applies if you have offices, facilities, things like that. I would note that the healthcare providers, hospitals, right now, there is a law that does not provide them with an off-ramp for religious accommodations. That is being heavily litigated, but that is the state of where we are. Oh, if we go back to the next slide. Thank you, Randy. I do want to make note that this relates to private employers, these mandates. Most of the states in the country also have special legislation that's requiring now that there be vaccines for people that either work for the state or the city, so public employees. There are also vaccine mandates that relate to people that have contracts with state or cities. There are vaccine mandates required largely across the United States for healthcare workers, for people that are teachers or working in schools, for people that are working in nursing homes, for working in prisons. If you have contracts or subcontracts with any of those entities, you may have a requirement that your employees are also vaccinated. So just want to make that reference. All right, next slide. And then next slide. So a couple other things, just again, we're trying to do an update to keep people abreast of what's happened since we talked last. So if we go to our next slide, one question that we've gotten from a couple different folks is, now that they've rolled out this plan that every individual is entitled to get 8 tests a month per person covered by your health insurance under this new Biden plan for the duration of the COVID public health emergency, can we require our employees to use those essentially 8 free tests, OTC tests, a month as part of what they're using for our testing requirement, or if they are allowed to have an exemption? The answer appears to be no. We got some FAQs from HHS and DOT, as well as DOL, that said these are actually meant to be for personal use, not employment use. And in fact, the healthcare providers can ask some questions to confirm that the tests are not for employment purposes before they issue reimbursement. So now you can still publicize that these tests are available to your workforce so that hopefully they use them to limit coming into the workplace as positive. so that you limit the amount of people in the workplace that are testing positive. You can also advertise the fact that there are COVID tests available for free COVID tests. By the way, New Jersey allows you to get a free COVID test. I've done it twice, and they've shown up within a day or two. It's amazing how quickly it came. The other thing is we do have clients that are working with their health plans to provide coverage for the testing for employment purposes, so that their workers can go to a CVS or whatever location and just say, I'm here for a COVID test, and at no charge to them. So if you're going to do a testing alternative, or if you have to do a testing alternative because you have people that have requested and qualified for an exemption, that's probably the easiest, quickest, most effective way to do it. Next slide, please. New Jersey, what's specific to what's happening in New Jersey? I note that Governor Murphy, maybe he's been talking to Dr. Strom and says the end is near, but he's saying it's time for New Jersey to learn to live with COVID-19. That probably means that we're going to see less and less in terms of restrictions. But I would say less than 2 weeks earlier, there was a more aggressive action taken where he eliminated the alternative to have healthcare workers test. So it is truly a vaccine mandate now in New Jersey for healthcare workers, and then including the booster. And then also we continued the public health emergency earlier in January. So that means that the vaccine and masking orders, testing orders that apply to government employees, teachers, the things that I talked about earlier are still in place, as well as contractors with the state. So I appreciate that, we all want to move forward, but I think right now we're still seeing that there are restrictions in place, at least for the time being. Next slide. Okay, masks. This is just constantly the question we get. People are wondering as they start to trickle back into the workforce, or they're there full time, do I have to wear a mask? Or my coworker's not wearing a mask, they should be wearing a mask. What is the story? So the CDC, and by the way, New Jersey says you should really follow what the CDC says. It doesn't make it mandatory, but it says this is what you should be doing. The CDC says that whether you're vaccinated or not, if you're in an area of high transmission, then everybody should be wearing a mask. That's what's recommended. The state is in an area of high transmission. Every county is in high transmission. As of the end of January 31st, 99.75% of all US counties were in high transmission. So wherever your employees were located or were traveling were likely high transmission. I checked this morning, New Jersey is still all red, still high transmission. The other thing is the CDC updated middle of January that really you should be doing N95 and K95 masks to be truly effective to prevent the spread of Omicron. If you go to the New Jersey website as of January 18th, they picked that up. They also recommend it. So to the extent that you may want to work that into your policy as a recommendation, to the extent you want to provide those masks, that definitely will help containment. So also, you can impose a stricter policy. You can say, we are requiring that people wear masks in whatever locations, either when you're on site, clearly if you're unvaccinated, absolutely. You could say, while we're in high transmission, we want everyone wearing masks. Whenever you're in a conference room. So that is something you can do. The problem here is it's the on again, off again fluctuation in what's happening that gets people confused. So I think that masks are probably going to be with us in some way for a very long time. And it's also a big challenge in terms of a lot of people don't want to wear masks. So when you're putting together your policy, obviously right now we're in high transmission. You want to be more conservative in terms of having wear a mask so you have less spread. But want to think about what's practical in terms of adherence, enforcement, et cetera. Next slide, please. And then also, to the extent you have employees in New York, there's been a lot of discussion about the statewide mask rule that requires indoors. Everyone has to wear a mask unless everyone is fully vaccinated, which is not necessarily easy to achieve in all workplaces, especially if you have someone who has an accommodation. That is going back and forth, but basically it's still in place. The other thing is the New York HERO Act also requires face coverings while it's in effect. So even if there's questions about what's happening with the New York State mask mandate, the New York HERO Act really requires that for right now, at least until February 15th, and will probably be extended for a bit of time, face coverings are required. Next slide, please. Okay, the boosters. So we've been wondering, you want everyone to be, quote, fully vaccinated. Fully vaccinated definition does not include booster status. We have been expecting they might update it. I think what they've done is an end run. We now see that the CDC is updated to say that they have something called up-to-date status for vaccines. What is up-to-date status? It means you've received all recommended COVID-19 vaccines, including any booster doses when eligible. And booster for Pfizer and Moderna means 5 months after the initial series, and for J&J 2 months. So I think what we need to do is modify our policies to not necessarily just say fully vaccinated, but go to this, you have to be up to date on your COVID vaccines. And you can cite to the CDC definition of up to date. So it appears that the fully vaccinated definition may not be modified, but rather they're using this up to date as sort of the alternative way to address that issue. So, and then when you're collecting evidence of vaccination, I think you want to collect evidence of any boosters and use the same kind of language. We want to collect, evidence that you are up to date, including the boosters. And then whether people are going to require another booster, if CDC says up to date means, the 4th booster, your policy hopefully will cover that. Next slide, please. All right, so leaning in, what are we going to be dealing with? Hopefully, your HR committee is discussing all the time, when are we going to talk about more than just COVID? There's a lot of things we're thinking about, but we're also I'm seeing this with clients in terms of challenges to be thinking about as we move forward and hopefully move out of the COVID-19 pandemic. There is going to be, I think, clearly an ongoing demand for remote work and hybrid work. I read a really interesting article this morning about the fact that, managers, senior management want people to come back for that more interactive, dynamic exchange. More junior people, apparently this survey said, don't want to come back. But the point of the article is the dynamic exchange isn't going to happen whether you're in the workplace or not, because people don't have time to necessarily just interact with people in the way that we're hoping, because they're too busy. With the great resignation, people are assuming more and more responsibilities as their colleagues depart, and that there's just this overall fatigue in the workplace. Where people are just too tired to spend that extra time to kind of chat with their colleagues and learn what they're doing and have that interdisciplinary sort of formative thinking and idea generation. So something to be dealt with. We still, we had those questions in the prior session. There's still a lot of stress in the workplace. We still have issues where there are unvaccinated children. Hopefully we're going to see, there's progress in terms of getting vaccines, but that's something to continue to account for. We're seeing a lot of questions as people are coming back with concerns of lack of compliance with safety measures. As I mentioned, we still have OSHA obligations. There still are obligations in terms of masking and things like that. Leadership training in the new normal being remote, hybrid, what's the appropriate way to manage people through computers that were, through the remote situation, things that's we're talking about. The other thing with the Great Resignation, another hat I wear is head of our pay equity group. I see a situation where people are throwing a lot of money in terms of bonuses and salaries to retain people and also to attract people. That's probably going to really throw off a lot of your compensation. You may go outside your guardrails as far as your pay bands, which may cause pay equity issues. So, something to also think about as you go forward. So a lot to think about, a lot to deal with, but next slide. It is Black History Month, so something to celebrate. And hopefully we will break out of some snow and be able to have some good interactive events to celebrate Black History Month. And with that, I think we open up for questions.
Terrific. Thank you, Lynn. And here on Black History Month. So we do have some questions for you. So that was terrific. Thank you for the update. We only have just a couple minutes left, but so any relief in sight on contact tracing responsibilities seems to be, lots of time spent on that with, in this person's opinion, perhaps diminishing impact. So what are your thoughts?
Right. So I think until the CDC pulls back on contact tracing, I think it's something we still have to continue. And it's interesting, we're actually getting complaints from people that are, because there's so much Omicron, where they'll say, I know that so-and-so tested positive and I was in close contact with them and I never got a phone call to put me on alert. So I feel like I have, you violated safety protocols and you put me at risk and my family at risk. So I think that that's something you still want to be following. The other thing I'll say is New Jersey, Pennsylvania, New York, in terms of COVID-19 litigation, top 3 states for the number of claims filed. Most of the claims are, retaliation type claims in that I raised concerns about how my company was handling proper protocols, compliance with safety measures relating to COVID. And in response, I suffered some kind of retaliation. So I think that you do want to be careful about pulling back too quickly on appropriate protocols. And hopefully, as Dr. Strom said, we're going to see less incidents. So that means there's going to be less time spent on close contact tracing.
Okay. So one more question. So you discussed what other states are doing, including some that are limiting the ability to require workers to be vaccinated. If you're a New Jersey-based company, but you have salespeople working in those states or employees working remotely in those states, can you still enforce a vaccine mandate?
So the answer is probably not. If someone is a resident of Florida and they're working remotely based in Florida, they're entitled to the protections of the state of Florida. So you're going to have to work within those guidelines in providing the exemptions that they're asking for. Or if they're in Tennessee, you probably can't enforce the mandate as to that individual. So something to take into account as we have people in other states or people that continue to work remotely.
Okay, great. Thank you. And Lynn, the key question that I asked Dr. Strom as he was leaving, same to you. If we have to do this again, which I hope we don't, will you be willing to come back?
Of course. I love my BioNJ folks.
Oh, great. Thank you, Lynn. And right back at you. We really appreciate your time and your counsel. So thank you to Lynn. Thank you to Dr. Strom. Really appreciate their time today. I hope that you found this to be valuable today. We hope to see you at future BioNJ events. Again, annual meeting, hopefully in person on June 9th, Bio Partnering Conference in partnership with JP Morgan and J&J Innovation on May 10th and 11th, with an opening reception on the 9th in person in Jersey City, outdoors mostly. BioNJ.org for the full calendar. And if you are not yet a member, I know Kim Minton would absolutely love to talk to you. So thanks for joining us today, everyone. Please stay safe and well, and we'll see you soon, hopefully in person.